very warm welcome to the event that is to discuss about why HMPPS is adopting a recovery orientation as a way to address some of the issues that we're facing currently within prisons and probation related to drug and alcohol use. I'll be your host today. My name is Mike Wheatley. I jointly head up with John Cowan the Drug and Alcohol Group, which is part of the Health and Wellbeing Division within the Rehabilitation Directorate within HMPPS. And it's great that we've got a whole series of speakers lined up for you today. And I'd just like to start by thanking you for making time for joining us today to be able to explore this issue and to talk around it and to just spend a bit of time thinking about why we want to adopt a recovery orientation and what the benefits and the practice outcomes can be by us all working together for this particular ambition. As well as saying thank you for you making time to join us today. Thank you to all of the speakers who you're about to meet and for the content that they've prepared to hopefully give you some valuable insights. We're going to be joined by Professor David Best, Larry Eve, Mark Grantham, Tim Roberts, and Jeremy Byrne-Thompson, all of whom have got a whole wealth, and I'll explain a bit later, of experience in this particular field, and are going to give us some of their insights in how this particular approach can lead to some positive practice outcomes and some direct benefits for those that we work alongside and we serve in. To begin with, though, we've just got some housekeeping. To help us get the best out of the meeting today, we've just started the recording because we've got one of the biggest insight events I think that we've organised previously, and I know there's a huge amount of interest in this particular area. So we will be recording the presentations. We won't be recording the Q&A session at the end, but for the whole of the bulk of the presentations that you're going to hear, we'll be recording that. Can I ask you to please keep your microphones on mute and your cameras off while the speakers are presenting, just to help us focus and maintain our concentration. We've got a whole background team within the Insights group who are going to be spotlighting the speakers, so you'll be able to see the people who are talking as well as the slides that's on the screen. But if you can keep your microphones on mute and your cameras off, that'll be appreciated. And there's also a Q&A function, which already Steve has put a contribution into that. If you want to make a comment or ask any questions, please use the Q&A function, not the chat function, the Q&A function to raise any issues. And in the half-hour session at the end of this webinar, we'll hopefully come and address some of the issues that's raised through that Q&A function. Them. So that's some of the housekeeping to help us get the most out of the event this morning. So just to quickly summarize, I think from our point of view of why are we doing this webinar today? And I think it's no surprise to people who work within the criminal justice system that addressing drug and alcohol use within criminal justice is really important. Within prisons, we are seeing on average between a third to half of our population being identified with drug and alcohol issues. In probation, there is a significant number of people with drug and alcohol issues, but we have difficulty in measuring them for a variety of different reasons. But taking all that into consideration, we do know we've got a significant group of people with drug and alcohol issues that are in contact with the Prison and Probation Service. And all the previous approaches that we've adopted over the years, we've had the War on Drugs campaign where we've been really strict on enforcement, and that's taken us so far. We've then had some movements to develop the treatment services within the local authorities and the communities and within the prison service, which has also made great advances in how we can support people with drug and alcohol use. But the issue still persists, and it's taken us so far, but we need to do more and we need to do better. So building on all of the previous policies and the strategies that we've had in place, we've launched a drug and alcohol framework. And essentially, the framework is not new policy, it's just an updated guidance for staff to try and develop a recovery orientation and to get them focused on the three key objectives of enabling recovery, reducing demand, and restricting supply. But within those categories, we've got 10 specific objectives that we're asking our staff within prisons and probation to focus on in order for us to develop a recovery orientation. And we believe, because we've scanned and we've looked at practice, not only within our system, but in other jurisdictions, and we've tested some of these new practices out, and we've seen some really promising good results. And the speakers that we're going to introduce to you next is going to tell you a bit about why this is important, what difference it could make, and give you some real life examples of how this can improve the system and the services that we have in place and take us to that level and reach the ambition where we want to be so we can better serve those that are in our care. So the reason why we're doing this is we want to try and create and develop a better system and better services for those coming into contact with us that will help address their drug and alcohol use. What that entails and how it's looked at, the speakers will be able to explain that. So I'm not going to hold up with any kind of the presentations any further. I'm going to introduce you to our first speaker, who has been an ally and a great champion and support to HMPPS for decades now. And Professor David Best has a huge pedigree within this whole area. Currently, he's the director for the Centre of Addiction Recovery Research at Leeds Trinity, but he also holds a variety of other posts within universities across the globe. He's an honorary professor at the Australian National University, as well as an adjunct professor in Monash University in Melbourne, and is also a senior scientist with the Public Health Institute in California. He's been a founder member of the College of Lived Experience Recovery Organisations in the UK and is a pioneer in developing the inclusive recovery cities movement across the UK, and he'll talk to us a bit more around this. He comes from a psychological and a criminological background and has worked in practice, research and developed policy in the area of addiction recovery and the rehabilitation of offenders. He is a prolific presenter and writer and has made significant contributions. He's got thousands of citations in academic work. He has hundreds of peer-reviewed journals and lots of books, over 70 books, chapters, but he's got a new book coming out in April, which I'm sure he'll tell you about, around recovery capital, that he's jointly edited with Emily Hennessy, and that's definitely something to put on your pre-order list within Amazon, because the book will give us some fantastic insights into why it's important to help support people develop their recovery capital. So David, with that, can I hand over to you, and thank you for making time to join us this morning, and the floor is yours.
Oh, wonderful. Thank you so much, Mike. I really do need to appoint you as my agent. That was a fabulous build-up. So I really appreciate that. It's a pleasure to be here. I think it's fair to say we have some really exciting opportunities within the Ministry of Justice and HMPPS. I mean, we know there are some significant challenges, but what I hope we're able to do is to come up with a strength-based model. So look, I've got various academic qualifications and backgrounds and titles and whatever, but the key, I think, to my warrant to knowledge in this area is I've collected about 4,000 recovery stories over the last 15 years or so in Scotland, England, Wales, Canada, America, Australia, New Zealand, Belgium, and the Netherlands. So it really is the synthesis of knowledge that comes from the projects that's involved in that informs me about what's going on. Now, the other thing is, why would we be interested in a recovery approach in a criminal justice setting? Well, there's at least three different reasons. One is the common occurrence of drug and alcohol use among individuals involved in the justice system. Two is common cause. A lot of the factors that are associated with drug and alcohol dependence are also associated with risk factors for offending. But crucially, for me, the third point is many of the predictors of recovery from drug and alcohol problems are shared characteristics with the qualities that predict desistance from offending. And they can broadly be embedded within a strength-based model, which is really what I want to talk about today. Now, when I started working in the recovery space, and I've worked in the addictions field since the early 90s, but when I started working in the recovery space, I think it'd be fair to say we were open to the criticism that the evidence base was weak around recovery. That's not the case now. We have a very strong, coherent, and consistent evidence base around both what predicts individual recovery, but also what works in supporting people's recovery. Can we go to the next slide, please? And it's really easy to summarize. So the first two sets of bullets on here on the left and right hand side basically say the same thing. If you had to summarize what we know about who will recover, you can frame it as jobs, friends, and houses, or somewhere to live, someone to love, and something to do. And incidentally, I was talking at the launch of Newcastle as a Marmot city, a public health Marmot city last week. And I presented this slide, and Sir Michael Marmot effectively said afterwards in the Q&A session, this really summarizes his social determinants of health model. And so we are reconciling inclusive recovery cities with the broader public health agenda, which I was absolutely delighted about, because these are fundamentally common characteristics. And I hope through what everyone says, but certainly through what I say today, the things that I'll be talking about are essentially a safe place to live that's free from threat, transition from network supportive of substance use to network supportive of recovery, and meaningful activities. And it's not overnight. Recovery is typically a process post-acute intervention of an average of around 5 years, and we split that into 3 phases. Early recovery is the first 6 months to a year, sustained recovery is between 1 and 5 years, and stable recovery is beyond the 5-year point. Why? Because the likelihood of relapse in the first year after detoxification is between 50 and 70%, and that drops to around 14% after 5 years. It plateaus at that point, doesn't really change. So we know that recovery is a journey over time, and that sounds like a complicated, demanding characteristic. We know it's not a linear process. We know addiction can be a chronic relapsing condition, but please note the bullet in the bottom right. Of all the people who have a lifetime substance use disorder, the best prevalence estimate we have, and this comes from the US Substance Abuse and Mental Health Services Administration, is that 58% of people will eventually achieve that 5 years of continuous sobriety. And that's crucially important. And indeed, John Kelly from the Recovery Research Institute would actually argue the figure is now higher than that, is more than 60%. And you can read that either as glass half full or glass half empty. It can mean 40% of people die addicted, or you can read it as 60% of people manage to make their way on in their lives to something more and beyond their addiction problems. And next slide, please. I'm going to go back to work that I did in Glasgow and Birmingham, which we refer to as the Goya study, which I'll explain shortly. And the purpose of this study was to predict what are the qualities that are associated with better well-being and quality of life of long-term recovery. And we essentially recruited around 200 people in recovery from heroin addiction and alcohol addiction. And we found 2 fundamental continuous streams to this. The first is the biggest predictor of how well people did in the recovery journey was changing social networks, getting involved with other people in recovery. And Longabout in the reanalysis of Project Match and Combine found the same thing. He argued that the single biggest predictor of alcohol recovery was transitioning your networks from networks supportive of drinking to networks of supportive of recovery. Who you spend time with matters. And we talk about recovery as a social contagion, but what you do with the time you spend with other people in recovery really matters. And so for us, the more basic activities you did, the better you did. So we took a simple count of these things. And what we found was spend time with other people in recovery, you expose yourself to social learning and social contagion, and use that time to engage in meaningful activities. Why Goya? Goya is a sophisticated scientific term that stands for get off your arse. The more you do, the better you'll do. Next slide, please. So we combined the data from those studies in the UK with data gathered by Alexandra Lodi in New York to start a process of quantifying recovery. And Granfield and Cloud in the late 90s had come up with the term recovery capital, but it remained a relatively abstract term. And myself and Alexandra Lodi used the data we had from US and UK studies to start trying to quantify recovery. And essentially what we came up with was a model that there are 3 slices of the pie to recovery. Internal characteristics like resilience, self-esteem, coping, self-efficacy, communication skills. And they are the things that broadly take that 5-year journey to manage. However, you build them through the other slices of the pie. That it's by changing social networks, and collective recovery capital we now typically refer to as community recovery capital, is accessing resources in communities that affords people opportunities to make new social networks and engage in pro-social positive activities. So the aim of building that slice of internal stable qualities is mediated by an individual's capacity to access positive social support and access to meaningful activities. Next slide, please. And we've been measuring this since. So we now have around 20,000 completed assessments of recovery capital using a tool called the RECCAP. And I just quickly want to say, to mention a couple of things we've done. So there's now a block of 14 or 15 published papers on this. And we've been able to show that in a range of recovery contexts, that we can evaluate impact and effectiveness using recovery capital measurement to predict outcomes for people on the recovery journey. And this is based in recovery residences in Virginia in America. And what we found was providing people with more intensive supports for people who had low levels of baseline recovery capital, both predicted retention in recovery residences and positive outcomes. So we know that recovery capital is a kind of robust metric, and it fundamentally challenges traditional ways of doing things. Because many, many years ago, when I worked as a psychologist at the Maudsley Hospital in South London, when we measured how well we did, we measured it on the basis of how much we can reduce bad things in people's lives. Physical health problems, mental health problems, housing problems, relationship problems, and so on. But sustainable recovery doesn't work on those bases. It's much better predicted on those stable, strength-based things. Positive social relationships, stable, meaningful accommodation, purpose and meaning in life. Next slide, please. And one of the crucial things that you have to understand about how recovery happens, it's a twin-track process. There is a process of individual growth over 5 years or so, but there also has to be, for us, as people trying to support recovery, we need to create the conditions that allow recovery to flourish. In other words, we have to create the conditions that assertively links people to community resources that are beneficial and positive social networks. And for this reason, we typically refer to recovery as an outside-in model. Traditional treatment, talking therapy, pharmacotherapy is an inside-out model. You change what goes on in people's heads and bodies to try and change what goes on in their social world and their broader life. Recovery doesn't work like that. Recovery is an outside-in model, particularly for people with very low baseline levels of recovery. The overall aim and philosophy is to create conditions that maximize the chances of individuals initiating and sustaining recovery, and by creating meaningful pathways to community resources, we challenge stigma, we build opportunities for giving back, and we create communities that are more actively and assertively engaged. Recovery is not aftercare. And an effective recovery model works as a mechanism for breaking intergenerational transmission of drug use and crime. So it's a form of targeted prevention and makes visible recovery attractive. Next slide, please. And the model we have developed for this is called Inclusive Recovery Cities, where an inclusive recovery city is a city where the implementation of recovery models and principles make the city a better place to live for everyone, and which implements the idea of a recovery-oriented system of care at a city level. We now have 32 inclusive recovery cities, the two most recent being Tampa Bay in Florida, where I was able to go and do some training a couple of weeks ago, and Cape Town in South Africa, which is going to start the inclusive recovery cities movement in Africa, which has been really exciting for us. What's the idea here? Well, the idea here is that an inclusive recovery city celebrates recovery through public events, creates pathways to improved social connection, and changes the model fundamentally from an inside-out model to an outside-in model. Next and last slide, please. So, we have a measurement metric at both an individual level and a collective level. A collective level we are applying in the criminal justice system, and I've been delighted to be able to work with Mike and some colleagues, and we're actually just about to start a case study model in an adult male prison in the Northwest, where we're going to test this out with individuals with long-standing recidivistic substance use issues. But the idea here for us on the big picture is recovery is not a linear journey. Recovery is not the end of a sequence of change. So because of the model we're aiming for, the aim is to create a collective model of positive change, to change overall community connections, not just for the recovery community, but for the wider community. And so the idea here is recovery is not just benefiting individuals, it's a social contagion that has a ripple effect that creates both targeted prevention, primary prevention, and changes the levels of connectedness. And we're beginning to gather some really positive evidence to show that that's the case. This is the big picture. The small picture is to switch from a strength-based, a deficits-based model in criminal justice settings to a strength-based model that's about where people are going to much, much more than it's where people are coming from. So I'm sorry this was a pretty quick and theoretical overview for early in the morning, but thank you so much for giving me the opportunity to talk about this. Mike, back over to you.
Thank you, David. And I think one of the things I take away from this presentation, but also your previous presentations, is of why there are some advantages for adopting the recovery orientation and developing that recovery support services and putting those in place, because it is different from treatment. I thought what's particularly helpful is the inside and the outside approach. Treatment is from the inside out, and then recovery is from the outside in, and creating that whole culture and that whole orientation can make so much difference to the people that we need to support. And thank you for taking time to explain that to us today. Our next speaker is going to delve a little deeper into some of the issues around how we develop the recovery orientation and some of the strengths-based approaches and the assets that we can utilize in order to do that. And the next speaker is Larry Eve. Now, Larry has lived experience of recovery and also the prison system. But I think for my experience with Larry is I've been able to spend time with Larry. He works at the Basement Recovery Project, which is just a few miles away from where I live. And I was fortunate enough to be able to be invited by Larry, and he took me out to show me that particular project, the services that he runs. And for Larry, not only does he talk the talk, but Larry walks the walk as well. Larry showed me a fantastic house that he offers out to accommodate people who need to go through withdrawals and support the detoxification process. He showed me the treatment services that he's integrated, or the whole project is integrated into the basement, and also just the mutual aid, the support services that are on offer on a daily basis. And the people in the Halifax community use this project, and you could see the tangible benefits to all of those who actually engage with the project. And Larry is one of the catalysts and the facilitators that enables all of that to happen. He's the living proof that you can make a difference. But also what I like about Larry is Larry's been one of our guest speakers to loads of different events from members of staff across HMPPS. And he's the most commonly cited person. Some of his lines, his quotes, and his stories, the narratives he tells, are repeated to me most often by the people who I meet. And that shows that he's having an impact and certainly making people think differently and helping them to develop these recovery orientations. So thank you, Larry, for making time again. I'm not going to steal any more of your time, so over to you. Thank you.
Thank you very much, Mike. I think I'm blushing a bit now. I've never quite had an intro like that. So thank you very much. I hope I can do it justice. I'll have to start by saying, a massive thank you for an invite to such an amazing event. I think the last time I was invited to an event this big was back in the early 90s when I was raving in the illegal acid house raves in some dirty warehouse somewhere, taking copious amounts of ecstasy. So yeah, it's the biggest event I've been to, but yeah, that brings the memories back. If I can move on to the first slide then. I'm going to practice just talking for 10 minutes. Anyone who's ever met me, and I'm fortunate enough to know quite a few of you guys that are on here, you'll know that it's a real challenge for me to talk for just 10 minutes. So I'm going to set myself a timer in the hope that I can stay on track. But so a little bit about me. As Mike alluded to, I'm a person in long-term recovery. I chose abstinence as a basis for my recovery as well, because I'm one of those people that use drugs and alcohol that doesn't have an off button. I don't possess that off button. No matter what the consequences, I just can't have and don't have an off button. So I chose abstinence as a way of building my recovery. Safe to say that I've been in recovery for nearly 17 long years now, and I've enjoyed every single one of those years. I've worked across a variety of settings as well. I think I started as a volunteer and a peer mentor for the inpatient rehab that I was with 17 years ago, and came through as a volunteer. My first job ever was making sandwiches for the peers, and I absolutely loved it. And I guess I've just grown from there. I worked in a variety of inpatient detox settings, inpatient tier 4 settings, rehab settings across. But 13 years ago, I started as a sessional worker for the Basement Recovery Project. Immediately, there was something different about this organisation. There was something people focused. There was something about this organisation that really I gravitated to. I've worked my way through there for the past 13 years, from a sessional worker right up to the fancy title of operations manager, which is just a flash title for I do everything. And I do it with passion, and I do it with love, and I generally enjoy what I do. I guess alongside that, I'm also a Clero leader as well, as part of David. David Bessie sits in our Clero as one of our advisors, and I take great pride in the fact that as an organisation, as an individual, that we're part of the College of Lived Experience recovery organisations. And the Basement Project is also a consortium member with some successful funding from OID quite recently to really roll out the Clero movement locally. Some of the services that the basement deliver, and Mike alluded to some of it. I mean, we have a housing model which is second to none. I think we are the front door of treatment services in Calderdale. So the front door to a treatment services in our area is a recovery hub, not a treatment centre. There are no waiting rooms where we are. There are no lanyards. There are no security cameras. There's no bulletproof glass on the reception desk. We've broken all that down. We've created psychologically informed environments where people want to come to. I think alongside that, some of the other services that are developed over the years is that we have our own home office license to dispense things like methadone and other OST medications, and we dispense them from a recovery hub. I don't know anywhere else in the country where you don't have to queue up in the shitty methadone queue at Boots in your local pharmacy, where you can actually come into a recovery space and achieve methadone. It's we also have our own enhanced community detox facility and a quasi-residential sober living house model. And again, I think Mike alluded to it. We came and showed me around that. And what it's done, it's broke the whole detox process down, and it's made the detox process a homely social process as opposed to a purely clinical process as well. I think some part of our success locally as well is that we have become a key alliance partner, and in Calderdale we've developed what we call a professional family approach, and in that all the stakeholders sit around the table and we have an equal seat at that table, and our voice is heard at that table. I guess we describe ourselves as disruptive innovators and a critical friend. And what that critical friend in every family, you'll probably know in all your families, there's this critical friend who's normally always right and normally really quite irritating with their points of view. Well, that tends to be us around the table in the alliance that we work in locally. Next slide, please, Dan. So I think it's been a real privilege. We have been instrumental in the design of this new framework from the get-go, and we spent many months in many meetings across quite a long time, putting our voice and our lived experience and our knowledge into this essential framework. It was a really beautiful thing when this framework, the draft copy, and it came back to us, and I looked at it, and all of our points that we raised were embedded into that. That was a real special moment, because lived experience up to now hasn't really had quite a seat at the table like that. I guess you can't create a recovery orientated system without the voice of lived experience. You can't. And I reference on my slide, it's a bit like building a road and you don't really know where it's going, but we're going to build this road, but we have no idea where this road's going, but let's just hope it gets to where it's going. And a couple of points on that is, you can't solve a problem. We have a massive drug problem and alcohol and addiction problem in our prisons today, the same as we do in our communities. And that problem cannot be solved using the same thinking and the same processes that have contributed in some way to causing the problem in the first place. So something has to be different in that. I think another fundamental reason why you have to have the voice of lived experience when you're co-designing recovery-oriented systems is because everyone on this meeting today will know that recovery and addiction doesn't do 9 to 5, Monday to Friday. But the services we've built and all the excellent staff that we have that are running those services, they work 9 to 5, Monday to Friday. This isn't a 9 to 5 problem. My addiction doesn't check out at 5 o'clock and clock back in at 9 o'clock. So there's this massive gap that sits outside of service provision that really where some of the problems really lie. Lived experience plugs some of those gaps. We are the end of that road to get it to its destination. What do we offer? We offer understanding. You don't really know this system until you stood in those shitty methadone queues on A-Wing, queuing up for your next dose of methadone. You don't really understand this system until you've been assessed after assessment after assessment, 127 questions about everything that's shit in your life and everything that you're bad at. You don't really understand the system until you've been part of that. If you've completed all the courses in the prisons and you've graduated from all the programs and you're still stuck in the system and you're still getting worse and you're coming back to prison every 2-3 years and your methadone's going up and up, you don't really understand that system until you've been in it. We also know a little bit about the gaps as well that are currently in the prison system, and some of those are the outdated psychosocial interventions that are on offer today. Some of the interventions, they don't work for a lot of people. I'm one of those people, and I've met countless people like me in the prison system where them psychosocial interventions, they're not working for us. How do we know they don't work? Well, I'm still here. I'm still coming around in that vicious cycle of offending and reoffending and addiction. I'm still here. I'm still not seeing enough abstinence-specific interventions in our prison system as well. It's a massive gap. Abstinence is still a bit of a naughty word in that. Mutual aid as well, access to mutual aid. I did some presentations quite recently to a senior level team at a leadership team at one of the prisons, and I said, I really have to apologize. You can't call this a recovery wing if you don't have mutual aid in it. I'm really sorry, but this isn't recovery without this. And I think another real gap in the system as well that we've noticed is that there is a lot of people falling through the cracks in terms of internal transfers. I can be doing really well in a local prison on the ISFL, doing really well, engaging in mutual aid. I get sentenced, I get sent to another prison, I go straight on a GenPop wing and fall through the cracks. This policy and this framework is about people. It really is about people. And I can give you from the table of contents from this framework, you'll see that a person-centered approach is mentioned in number one. Psychologically informed practice and environments cannot do that without lived experience. Utilizing the skills of lived experience is key in objective 2, and creating a learning culture. All of those are about people, and this policy is very much about that. Next slide, please, Dan. Some of the meaning that lived experience brings to the table. We sit on the Prison Drug Strategy Board. We are the voice of lived experience in that board. And I must have a big shout out to Di Lewis for having the courage and the bravery to let us into that world. We sit as the critical friend on that regional drug strategy partnership. We take the role very seriously, and we brought some real meaning to that environment. In terms of hope, we've generated lots of hope. I've done some recent work. We call it a bus to bed. And literally, I have been sitting on a prison bus, and I have been at the prison bus. I've gone through the reception process. I've gone through the first night wing, a bit of a mystery shopper, and I've been evaluating the process and looking through the lens of trauma and looking through the lens of enabling recovery and writing reports at the end of that. It's gone down a real treat. It really has. And in terms of purpose as well, probably some of the biggest work we're doing at the moment, and I have to give another shout out to Katie Lawley and her team at the Drug and Alcohol Group. We've started a pilot of ISFL pilots across the country. So we're evaluating 11 ISFL recovery spaces across our country at the moment, and we're taking the recovery temperature of those places, and I'm writing reports at the end of that in terms of a roadmap to get from where you are now as an ISFL, this dedicated recovery space, and how you might be able to build recovery interventions into that. Next slide, please, Dan. Doing well here. Some of the challenges: the vetting process, not ready to receive us yet. Us with lived experience, we're really struggling to get through the vetting process. And yet, Mike, with his box of spanners, who's more likely to bring drugs into the prison than me, can get through the vetting process really quite simple. Bit of an head scratcher, that one, but the vetting process itself isn't ready to receive us. The Standard Plus system and the vetting system needs a really serious look at. I think recovery has to be in the core policy. Part of the assessments that I've been doing, I've been looking around different establishments, and I've been noticing core values and core visions of the different systems. And I see safety, and I see rehabilitation, and I see integrity, and I see diversity. In those core values, we have to have recovery as a core value for the treatment services that are working in the prisons, and also the prison service itself. LEROs, again, lived experience recovery organisations, in our view, need to be written into tender specifications so that we have a seat at the table in those environments. Mutual aid, again, is another postcode lottery for prisons. I've been in some establishments that are really doing well with mutual aid, and other establishments that are really struggling to get it going as well. It has to be in that. And of course, recovery and trauma-informed training as well. I spoke to so many operational and non-operational staff, and I spoke to them about what training have you had about supporting people that are traumatised? Very little. What training have you received in terms of scattering the seeds of recovery and knowing how to nurture those seeds, and knowing how to nurture someone that wants recovery, and understanding what that means?
Let's see if Larry.
As well, I think I've gone a little bit over, Mike, so I'm going to hand it over back to you.
Thank you, Larry, for all of that. And Larry, you've just had a question come in about mutual aid and what we mean by mutual aid, and if you've used that as part of your recovery process. But mutual aid, we're referring to like the fellowship programs and the support that's offered by those social groups that we can bring in to help support people who are going into long-term recovery. I don't know whether Larry's frozen or whether it's my system there, and see everybody else moving. But thank you to Larry for all of that. We're going to pick up some of the questions that are in the Q&A, and we'll take them back to Larry. But essentially, the key message that Larry's making there is working together. It's all about the person-centered approach, and certainly the recovery orientation is about putting the people first and looking at their specific needs, utilizing their strengths and their assets to best effect in order to create the support that's needed for people to change. Now, our next speaker is Mark. Mark Grantham. Now, Mark is one of our drug strategy leads at HMP Featherstone, and Mark has a variety of experience since he joined HMPPS decades ago. He's been working delivering cognitive behavioural programs and has experience in a number of different prisons, but currently Mark is one of our drug strategy leads. And drug strategy lead is something that we've been fortunate enough to be able to get funding, and we've recruited over 50 drug strategy leads, and we're optimistic that we're going to get funding to expand that network even further. And the reason why that's important is because drug strategy leads, people like Mark, are the people that help us in headquarters to actually make the changes that we need to see. They're the ones on the front line that are helping support and helping develop these services. So Mark's going to tell us about some of the initiatives that he's been working on within his particular prison. So Mark, over to you. Thank you. Mark, you're on mute.
Classic. My apologies. Thank you very much, Mike. Thanks for the kind introduction and kind words. I'll jump straight in. So as Mark said, my name is Mark Grantham, and I'm currently drug strategy lead for HMP Featherstone. I've been in post now since September 2022, so a couple of years. I just want to start with a quick preface to this presentation by acknowledging the fact that this is going to be...
My volume won't turn down.
Sorry there, Mark. Can we just say there's some people who's got background noise? Can you just check to make sure your mics are on mute, please? Sorry, Mark.
No problem. Thanks for that, Mike. Just to acknowledge the fact that this is going to be very much a whistle-stop tour of some of the things that we've been doing at Featherstone that specifically align with the new HMPPS drug and alcohol framework and some of the broader aims and issues that have been mentioned already today. So 10 minutes isn't a long time to talk about some of this stuff, so I'm going to be as swift as I possibly can. That said, there will be opportunity later to ask some questions. So just a really brief background on me. So prior to coming into this post, I spent around 10 years working in prisons, and the majority of those years were spent working in drug and alcohol teams before becoming a manager and moving on to this more strategic role back in 2022. And a bit of background on HMP Featherstone. So Featherstone's a Category C adult male prison with an operational capacity of 687 based in the West Midlands, and it's predominantly a trainer prison. So we do have men with us for often a fairly significant amount of time to be able to work with them and support them prior to them progressing on in their sentence or indeed release. And it's worth mentioning, highlighting about Featherstone that for many years now we've had quite a significant high amount of reported drug and alcohol use amongst our prison population. I'll not bore you with the figures around this, and it's a significant thing across the estate, as has been mentioned already today. But the fact is that drug use, it really poses a real risk to the health of the men in our care and a significant amount of risk to the staff who are responding to these incidents on a regular basis. We also know that around 60% of the men in our care have an identified need around drugs and alcohol. So we know there's a really high need for effective drug strategy in our prison and indeed recovery pathways. So, and that's not only from the amount of reporting, but from the criminogenic factors. So over the 2 years that I've been here, there's been a lot of changes at Featherstone, and there's a lot that we're still working on. And for the purpose of this presentation today, I'm just going to focus on 3 key areas, and they're the 3 areas that are up on screen. So building a recovery pathway and introducing recovery-focused environments, creating a shift in culture and attitudes toward drug and alcohol use in our prison, and working in partnership and collaborating to deliver effective drug strategy. A real mouthful, some of those titles. I didn't think that through beforehand, but I'll try and explain a bit about what I mean there in the next few slides. So if we go to the next slide, please. Okay, so recognising the initial challenges through prisoner engagement surveys. So as mentioned previously, there's a really well documented history of drug and alcohol use at Featherstone, and through prisoner engagement surveys completed, we identified that many men at Featherstone did not feel as though recovery from drugs was easily accessible or indeed accessible at all whilst in custody at Featherstone, which is obviously a real concern. But when we looked at this objectively, it's quite easy to see why. Firstly, it appeared that our commissioned substance misuse services were quite a small team and sometimes not able to effectively meet the scale of the need at Featherstone, and we can't rely solely on them to do that, which has also been a kind of a criticism of prisons in the past. And I'll discuss a bit more around what we've done with that team to try and improve that situation later on. And secondly, if men at Featherstone did decide to pursue recovery, they would need to do so on a wing that was not suited to the needs of someone in recovery. And as Larry's kind of mentioned previously, it is a lot about the environment we're creating. So these environments didn't really promote recovery. In fact, on occasion, you would have dealers and facilitators of drug culture living literally next door. And when speaking with some of the prisoners that completed this survey, they described it as trying to attend an Alcoholics Anonymous meeting or a mutual aid group whilst living in a pub. You know, it's there and it's readily available, and it makes it really, really challenging. So this really identified the need at Featherstone for some recovery focused spaces, which leads us onto the next point here. We were really, really fortunate to have the opportunity to bolster our recovery pathway at Featherstone through the introduction of a drug recovery wing and incentivised substance-free living unit. And these are fantastic initiatives led on by the National Drug and Alcohol Group, both of which have come with additional financial support to incentivise and improve the spaces that we have in the prison. But most importantly, the DRW that we've got, the drug recovery wing, it came with additional staff to be dedicated to the day-to-day management of that unit and supporting the men engaged in the programme. And we've been really fortunate to get some incredibly passionate and talented staff that really have impact on those units. Now, although these initiatives, they've been fantastic for Featherstone, and they haven't always been the easiest thing to set up. We've faced multiple barriers along the way, not least of which being population pressures, which for those that work in prisons will be able to appreciate that, and for those that don't, this might be a bit of a difficult concept to envisage, but we're trying to create specialist units for a specific cohort of prisoners, of individuals with really little space to manoeuvre. It's a real challenge for us. This makes the process more challenging and time consuming, but nonetheless, these units, they've been remarkably successful and have allowed us to create spaces that support recovery culture in a much more person-focused and non-stigmatising way. Or at least that's very much the hope and some of the feedback that we get. And if I had more time, I would love to share some of the individual success stories that we have from some of the men that are have lived on these units. But that hopefully will be a story for another day. As it stands, we have a drug recovery wing that houses 72 prisoners, and as of February, we now have 2 incentivised substance-free living units that house a total of 95 individuals. And these units are advertised around the prison. They're available to all men that meet the criteria, and they create our recovery pathway now at Featherstone. So now all prisoners or all men that arrive at Featherstone with an identified need around drugs and alcohol, they'll be made aware of the DRW and the pathway that's available. They can register their interest in pursuing this recovery via our peer mentors that will meet them at induction. And we've also got the general application process that sits within the prison as well. So this is something that's really been missing for Featherstone previously, and we're really proud of the work that's going on there, albeit there's lots more work to do, of course, and we're kind of committed to doing that. So just move on to the next slides, please. Thank you. So moving on to the second key area of focus for us at Featherstone, and that's creating a shift in culture and attitudes toward drugs and alcohol use in our prison. So there's a lot of evidence now available to us, and again, it was touched on earlier on much better than I can kind of elaborate on it, but there's a lot of evidence available to us that recognises substance misuse as more of a health need than a behavioural issue, and evidence suggests that we should be aiming to firstly understand why a person is using drugs, and secondly, how we can encourage that person to engage in the support that is there. And as we know, this isn't always the widely accepted view in society, and drug use still has a stigma attached to it for many, sadly. And the attitudes and beliefs in prisons, they typically reflect that of society. So it won't be a surprise for you to know that some of our staff and some of our prison population, they consider drug use to be a behavioural issue too, and therefore we should respond in a punitive manner, loss of privileges, take the television, less time out of cell, and this is really understandable in the broader context of things when we consider the fact that drugs are illicit articles in prisons, and having drugs in your possession is effectively breaking prison rules. Staff up to this point, they've been implementing these rules by enforcing punitive measures, and this is very much dictated by policy. You know, they're doing their jobs. So it's, again, a real reason why this framework, this new framework, is so important in shifting that picture of moving away from punitive measures to more supportive measures for those that we know are using illicit drugs in prison. So we've tried to do this at Featherstone, and we take guidance from the evidence that's out there to create a shift in these attitudes. And we've tried things like embedding the CHIME framework. So I know Joe's going to talk about this in much more detail later on. Into our processes and policies wherever possible. And to support this, we've delivered full staff training days where all available staff can attend and be briefed on processes, policy and approaches when working with people with drug or alcohol needs. And this at times is again quite a challenging thing to do in a full-time nature of prisons and prison regime. We had to be really creative to find the best ways to deliver training to staff, and it's an ongoing task for us. But we've had some real success, and in these sessions we've looked at areas such as key worker guidance for drug using men, so tying into the OMIC model, reporting processes when finding someone in the influence and how to manage and handle that situation, support services that are available within the prison. Not all staff still are fully aware of what we're delivering and what we're trying to achieve, and the referral pathways to our specialist units, and even nasal naloxone training for prison staff that we could be used in the instance of kind of opioid overdose. And the response to these training days has been overwhelmingly positive from everyone that's attended, and we're really pleased with the work that's going on there. We just now need to commit to continuing to do this as frequently as possible. We've introduced rehabilitative adjudications for prisoners placed on report for drug use. So where men in this prison have been identified as having used drugs through the mandatory drug testing programme, we tried to replace that punishment aspect with a more supportive wraparound care. The primary aim here is to support that person into the services that are available, rather than jumping on them and saying, you've done something wrong, let's punish you. We've also introduced specific interventions for prisoners using drugs or alcohol in prison. For example, challenge and support intervention plans for drugs, aka drug CSIPs. And we've offered staff guidance on how to approach and manage these. We've also built in some quality assurance process to make sure that we are delivering it to the best of our ability. And most importantly of all of that, we've rewritten our local drug and alcohol strategy to reflect all of the above, so that fundamentally our policies reflect our approach, ensuring that it's something that we've committed to long term. And it's worth stating at this point that this is very much a work in progress. And actually what we're trying to do here is promote supportive measures, community-based ethos, therapeutic environments. And actually we're trying to do this whilst working in a prison environment, which isn't very therapeutic by nature, as Larry kind of referenced earlier on. This takes time. It's no small task, but nonetheless we are seeing some success, and I feel like even in the 2 years that I've been working in this position, there's been a significant change. So that's really positive to see. And finally, so just last slides, please. Thank you. Very quickly, I'll move on to the final key area for us, and it's working in partnership and collaborating across the prison to deliver effective drug strategy. Now, I really haven't got much time to talk through this, but it'd be completely remiss of me to overlook the value of collaborative and partnership working when trying to deliver any of the points that we've touched on so far. Fundamentally, drug strategy, it's not an island, meaning that it simply can't be effective in isolation or owned by one person within a prison or function within a prison. It must be agreed, embodied and delivered across all areas to have the impact that we know it needs to have to improve outcomes for the men in our care. And secondly, we try to work closely with our commissioned expert services, both within the prison and external, especially in preparation for release to support things like continuity of care. And we've got fantastic commission partner services at Featherstone, and these are vital to the rollout of drug strategy on a day-to-day basis in supporting the men that we have here. And there are lots of examples of this where we've worked together really well on a day-to-day basis, whether that's delivering the training. We've done that together collaboratively, ensuring partners attend our drug CSIP reviews, attending the monthly drug strategy meeting, and mapping our continuity of care, both internal with internal and external partners. All of these are collaborative tasks that we work on consistently, but there's been larger pieces of work as well, like submitting a business case to NHS England for additional recovery workers to be based on our drug recovery wing. And that was a significant success for us. And our joint working has actually led to Featherstone being shortlisted for a Health and Justice Award. And for those that know, you'll appreciate this is real great recognition for the staff on the ground and what they're achieving on a day-to-day basis. And final point from me is around SRT engagement, support and buy-in. And as mentioned, drug strategy, it cannot work in isolation. To embed drug strategy and to have the impact that we need to really adopt these into our processes, policy and attitudes, as we've discussed. So this very much comes from the top, and at Featherstone, we're really fortunate to have a governing governor and a deputy governor that believe in what's being delivered. They've seen firsthand some of the successes from these processes, and they very much have bought in to what we're doing here. And this has been and will continue to be essential for the ongoing success of drug strategy at Featherstone. And with that, I think I'm very much out of time. So thank you all for your time, and I'll be available for questions afterwards, and I'll hand you back to Mike. Thank you very much.
Thank you, Mark, for that. And I think there's some things that you touched upon there within the Q&A. One of the questions was the final point you made there around the developing the recovery orientation can't be done in isolation. We have to work with our wider different departments, purposeful activity, our regime plans, our housing services, our employment services, in order to get the best effect. So that multidisciplinary approach, I take that away, but that's one of the points that was raised in the Q&A. And also, Natalie McKee asked a question around MDT, and you mentioned restorative adjudications. We're starting to think differently about the use of our random mandatory drug testing, and that's something that James Timpson, as our prison minister at the moment, is currently reviewing. So we're optimistic in the months to come that we will see some changes around adopting a less punitive approach and building on all of the good practice that we've started to develop. But it takes time, as Mark said, to do this. But thank you, Mark, for all of that. And I want to introduce you now to another one of our network ambassadors, one of our partnership managers, Tim Roberts, who works within the Northwest. Now, Tim is part of our community teams, and it's part of this network that's essential in being able to build recovery pathways and link people into the required programs to get the support that they need. And Tim is doing some amazing work across Merseyside in being able to get embedded into all of the different initiatives, all of the assets that's in the community that people can tap into. But Tim is involved in all of them and is helping develop support systems and pathways for people who are coming on into probation or are prison leavers to be able to get the most out of all of those opportunities. He's got lots of experience working in health and justice for many, many years in a variety of settings. He's also worked in academia and done research, as well as a lot of knowledge transfer projects. He's worked in a number of different prisons and a number of different initiatives associated with prisons. I'm not going to steal any more of the thunder, Tim, but thank you for making time to meet with us today. You're an essential part of our whole team approach, but the floor is yours, sir. Over to you.
Thank you, Mike. So thanks for the introduction. So as I said, I'm Tim. I'm going to race through my slides because there's a lot to cram in, and hopefully it will follow on from previous speakers. So I am a Health and Justice Partnership Manager from Northwest Probation Region. I'm going to talk you through what our function does, but then also our involvement in operationalising the framework in the community. Also a little bit about what it might mean, what it will look like for probation practitioners, our delivery partners, and for people on probation. So if we could go to slide 2. So this is quite a busy slide for us to start with, but essentially, a bit of a plan on a page for what we do here, and it explains the health and justice function and why we're so closely aligned to the operational framework. So the health and justice function is a national program. So my function is replicated in every probation region nationally. The activity, you can see our vision and our mission statement there, but we work across 3 core areas of business, and all of those focus on recommendations from that initial Dame Carol Black review. So the first is around continuity of care. So we do work very closely with our prisons, their providers, our partners across the drug and alcohol community spectrum to reach that government target of completing a minimum of 75% of all transitions of clinical structured treatment from prison to community. And those are real outcomes for people to restart their treatment journeys in the community and stay on track to achieve their recovery goals. And so we've done initiatives locally, such as a Lancashire release pamphlet, really simple idea of a booklet given to all prison leavers returning to Lancashire from anywhere in a prison, anywhere in the country, outlines the services and the service offer in the area they're returning to, as well as being a resource pack for those wider community services, third sector organisations and mutual aid groups to talk about what they offer. It was designed as an aid for prison leavers, but it also helps practitioners to clarify their recording data and the criteria for the NDTMS drug monitoring system that measures that continuity of care target. Our second big area of work in the drug and alcohol field is around rebuilding and helping to deliver high quality community sentence treatment requirements, so drug rehabilitation requirements, alcohol treatment requirements, and mental health treatment requirements. And we support our operational teams in probation delivery units, our court teams, judiciary, and again, our partners in the drug and alcohol providers to improve those processes that facilitate these orders and the offer of service that's available to those sentenced to them. And the Health and Justice team in region, again, recently we co-created a film. It's a great piece of work with Calico for use at court with potential candidates for a DRR and ATR. And it focused on using the voice of lived experience. We had real stories from people who were telling kind of like what had happened for them, what their journey on a DRR or an ATR had been, and the impact that coming into treatment had on them, and showing that they can and do work. That next box is around partnerships and building effective partnerships, and I'm going to come on to that in my second slide. And the third box is around health inequalities. And that's an expanding portfolio for us in the health and justice. As we heard from Prof. Best and previous speakers, recovery capital is not just about drugs and alcohol. And when we work with our partners across the system, we look at those wider determinants of health and that can affect a person's ability to recover. We see how important it is to get the right services to the right people at the right time. So it means that we're now covering and developing national strategies around, gambling harm, self-harm and suicide, neurodiversity. We're working really closely with our ICB colleagues around the Core 20+5 agenda, health programs such as Hep C elimination, liver screening, healthy heart programs, early cancer identification, all different factors. And of course, we've been rolling out on the naloxone program and other harm reduction initiatives such as nitazene's awareness and training and information sessions about drugs which are entering the mainstream and require treatment and recovery solutions such as ketamine. So that's the work that we're across in the health and justice program, and how we're drawing from the drug strategy to build a recovery support system for people on probation. So in this transition, what we're really talking about here is building a bridge, and building as many bridges as we possibly can, so that there are pathways for all the different types of recovery needs that our people have. It's not necessarily just about clinical treatment. If a person's had a successful kind of like role as a mentor on an ISFL in a prison, then what can we do to marry up the skills that have been built, the confidence that's been gained in that, with a role in a community organization or in a mutual aid organization? Again, and I'm going to keep on repeating this, it's about continuity. So equally, and just going back to the previous slide about partnerships, the key to the success of the model for us in the community is that interdependency between all the agencies. We are all working towards the same agenda to support some of the most disadvantaged, stigmatized and excluded and marginalized people in society. And so from that prison journey perspective, with probation, the relationship really begins at sentencing and all the way through the custody journey. It's not just about the release. And it's worth bearing in mind as well that over half of our population, about 52 to 54%, actually don't go into prison at all. So they're managed through community orders, and supporting them into planning and achieving their recovery goals requires a different approach. In that prison transition, though, we have to use all of the embedded assets that we have in the prisons, so the OMU and resettlement teams. And Mark referenced things like the prison inclusion meetings, absolutely fantastic forums that bring together drug services in prisons, drug service in communities, to talk through kind of like issues, trends, blockages that occur between services on either side of the gate. There's stakeholders such as ourselves, PNAP teams, drug strat leads, and lived experience and through the gate services, and now bringing in as well kind of like really important essential community connector services like Reconnect, Care After Custody, an innovative NHS service that supports people for up to 12 weeks pre-release as well as 6 months post-release. And it looks not just at that drug and alcohol support, but have you got a mental health need? Do you have a physical health need? And they'll help you bridge that gap between custody and community, get you registered into the right services in the right places, continuity of the healthcare, and they support recovery. The Dame Carol Black Review's also initiated lots of brilliant partnership forums that bring together all of the services in the community to address people's multiple needs. So we have combating drug partnerships, OHID partnership forums, local authority drug and alcohol partnerships. They're all spaces where we're sharing good practice, innovation, and introducing new services to each other and building new pathways. And these are all adding to the recovery capital building potential that practitioners can access, that social, personal, and community that Prof. Best mentioned. And we also know that a successful rehabilitative journey needs employment, training, education, a home, the right access to benefits, family services, all of those wider determinants of success. And I really feel that SDS 40, for those people who are involved in that, was a brilliant example of what can be achieved when we all do work together to make sure that those transitions across all areas of people's needs are addressed, and how they're all actually linked. And last on this slide is just, there are always plenty of opportunities for us to be creative in HMPPS with our different funding streams, to create those links and enhance services where it's needed, and to look to support initiatives that help us to do that job effectively. So my penultimate slide, I thought it'd just be useful to talk through about how the framework helps improve the way that we work with people on probation. So we work with such a diverse cross-section of society and need in the criminal justice sector, that it helps us to address that we have to make sure our approach recognizes this, and that there's a need to match the individual to the right support. It helps us to shape the training and the working practices that strengthen our understanding of recovery and desistance, bring us closer to the agencies and services that we partner with to deliver the specialist work. It promotes the rehabilitative capacity of the interventions that we have available to support and engage people into treatment. It promotes kind of the recovery through harnessing the voices of lived experience, opportunities to engage with lived experience, linking things like our Engaging People on Probation EPOP scheme with local lived experience recovery organisations. And all of that builds recovery capital through that wider partnership approach. And so what might this feel like for clients? Well, the aspirations to have a working approach that shows people on probation that we're trying to create a system that focuses on individuals' needs, building on strengths and assets. It listens to the people it works with and serves, but it also listens to each other and is communicating effectively with each other around the shared objectives and aligned goals that we have. And it demonstrates through practice that link between recovery and desistance. It can show people that the changes that they make around their drug and alcohol use have far-reaching benefits, not exclusively linked to desistance, but across all their areas of life. And I think that really, it results in the kind of engagement that's built on a bit of trust and encourages people to take that leap of faith and try something different and do something different. So the last slide is just something I wanted to use. It's from a paper written by Hazel Kemshall and Kieran McCartan in 2022. I like it. We saw in Prof. Best's presentation the work they did with Laudette in 2010, where it defined those three areas of recovery capital. And this sort of extends on that work and brings it together with the concept of justice capital and demonstrate that link between recovery and desistance. The idea behind the holistic person-centered approach to working with people really impacts their ability to review their recovery alongside the other work that needs to be done on internal processes, behaviours and rationales. And that kind of from the justice side, from a practice point of view, good practice in this area can and will lead to desistance and effective integration. So I have raced through, but kind of like I think I've managed to do that. Thanks for your time, and hopefully sort of lots of food for thought there.
Brilliant. Thank you, Tim. And yes, definitely lots of food for thought. And the thing I take away from that is around in isolation, working together, we can be much better than working in isolation in those silos. And certainly you're a testimony to how you've utilized all of the assets from your local area to try and get them all aligned and integrated and working together in order to create the best opportunities. And you've articulated just some of the opportunities that you've created there. So thank you for taking time to share that with us today. Our final speaker is Jerry Byrne-Thompson, who joined the probation service decades ago again and has worked in health and social care and drug rehabilitation centres for many, many years, and also has been a big advocate and a commercial leader within lived experience organisations. Jerry has a wealth of experience to share with us today, and her career both in probation and working within approved premises has been extensive, and she's worked in numerous different settings and helped with the whole transforming rehabilitation agenda, but now has come back to help us with the development of recovery-focused approved premises. So I don't want to steal any more of your time, Jerry. The floor is yours. Over to you, and thank you for making time to speak with us today.
Thank you, and thank you for having me on today. And I think everybody will agree the speakers have just been phenomenal. So much of what I say you probably will have heard in the previous presentations, but here we go. Next slide, please. So I'm just going to talk to you a little bit. I'm just going to explain first about what approved premises are. So you may know them more as, back in the day, they used to be bail hostels and then probation hostels. But since 2007, they've been called approved premises. So I'm just going to refer to them as APs because that's the vernacular. So they are the preserve for people who are identified as high or very high risk of harm. Primarily, people will come directly from custody, so they'll be on license, and it's where we can manage both their risk but help them rehabilitate into the community. So they are a resettlement function that is public protection. There's over 100 in the country. There are some for women, and the criteria for women, they can also be medium risk with complex needs. And the stay is usually, because of the pressure on the system, as Tim's alluded to, SDS 40, for example, the stay is being reduced to about 8 to 12 weeks. So following the Harm to Hope document, which was the Dame Carol Black review, as you know, and it had 3 key aims: reduce supply, reduce demand, and deliver world-class recovery. Our response to that was about setting up some proof of concept, recovery-focused APs, and to also think about how we could develop that recovery, that continuity of work that people have started in prisons into the approved premises. So it shows the locations based on the information in the From Harm to Hope document, which talks about which areas in the country have had the most crack and opiate use, where is their county lines, where is some drug-related offending going on, and it identifies that in that document. And then I overlaid that with which of the APs were in areas where we'd issued naloxone, because we've been doing that in the APs for around about 3 years, and we had drug-related issues. And then, because it's a whole systems approach, I also wanted to look at, well, which of the prisons had drug recovery units or ISFL, so we're feeders into those APs, and that's how we chose the 4 that we've got. We're opening our 4th next week, so we've got 3, but 4th is next week. So once we chose those, the model then was then very apparent. This is about really breaking that cycle from when people are using, they're offending, they're going to prison, they're getting well. And as Larry said, people have the best intentions, but when they come out, it's that lapse and that relapse. So this is really to try and avoid that. So that is the model. And then what we did is we had the locations, then we chose a LERO. We went to the College of Lived Experience recovery organizations, and we commissioned one of them to train the staff in those APs as recovery coaches. And you'll see the quote that I've got there about hurt as a center of all addictive behaviors, which is by fellow Canadian Gabor Mate. So it's about really asking people, not so much about delving into exactly what they use. Of course, we want to know that, but what happened to you? So we really focus on that trauma-informed approach is really critical. And then we also thought we'd do it, we'd asked the LERO to train people into that strength-based approach, that asset-based approach, about that recovery, developing that recovery culture, but their recovery capital as well. So really trying to train staff to work in that way with people. We're doing something really innovative. We're tracking those referrals, as Mark has said, about the drug recovery units and the ISFLs. That's never been done before. So if people get to that right wing in the prison, then we can really look at with their probation officer about if they're suitable for an AP, having them go straight to a recovery-focused AP. So again, it's that continuity that's not really been done before. Once accepted onto the pathway, we really try and prepare the individual for release by, we've got a pre-release workbook that we send to them, and that gets that individual to tell us, what are the risks, what are they worried about their relapse, what can we do, what are their goals and aspirations. So in there, it's got like a letter to future self. So when they come to the recovery focused AP, they can hit the ground running. Residents will spend 10 sessions a week on their recovery and rehabilitative activity, which is different from other APs where it's 6 sessions. So a little bit more time, a little bit more focus. And crucially, as Larry has said, and as everybody said, we've really tried to embed the recovery-focused APs being steeped into the recovery community, particularly mutual aid groups, of which we're really pleased to have such a good alliance with, if that's the right word. Next slide, please. So CHIME, I'm going to try and not have windmill arms here because I'm really passionate about CHIME. So people may know this, but it stands for Connection, Hope, Identity, Meaning, and Empowerment. So the opposite of, so for connection, the opposite of addiction is not abstinence, it's connection. So what we really try and do is make sure that we've connected people either to AA, NA, CA, SMART, something. So when they've left the AP, or even when they're in the AP and they've got racing brain and they're just thinking, oh, you know what, I'm just by myself here. It's to really have somebody that they can link in with so that they can avoid that. Really important. Hope, the opposite, we really try to give people hope. So it's not that we would say, the key worker would say, I've got hope for you, but it's about that belief that change is possible. Even if this is the 17th time that people have been around that cycle, it really is just trying to provide that opportunity for change. Identity, really important. The recovery coach that was we'd hired, they really spent a lot of time talking about stigma and shame. So if you think about us trying to make change, nobody wants to be defined by the worst thing they've done. So really trying to think about that, overcoming discrimination and how we can help people make those lasting changes. Meaning, it's absolutely crucial that we've got an environment that provides a lot of opportunity for people to get involved with things. They've got a purpose, they've got a structure, and that's crucial, not just whilst they're in the AP, but also when they're leaving the AP. We want them to have a schedule. We want people to be involved and part of the community. And I'm also a really big proponent for people doing some give back. So where we can, try and get people involved in voluntary work. And empowerment. You think about the changes that you make, that we all make in our lives. Sometimes something will work for you, but won't work for your sister or your family members. So it's got to be an individual approach. And that's what we really try and have. Just for example, in one of the recovery focused APs, there were quite a young cohort, and they said, you know what, we're not really kind of feeling it with some of the things you've got in place, but we really like the idea of recovery runners. So then we started to engage with that group. So it's really listening to people and not doing what we think, but actually listening to the diverse needs that people have, which is the best way to make some changes. Next slide, please. So that's about the recovery focused APs. We've also tried to introduce recovery in every AP. And as you heard me say, there's over 100 in the country. And people are at different stages of both their addiction and recovery. So it's really important. We've really spent a lot of time trying to make recovery visible, and particularly with mutual aid groups. So we have had myth busting sessions from AA. We had over 150 dial-ins, and some of those had rooms full of people, and that was about looking at a goldfish bowl meeting, what happens in an AA meeting. And then we're similarly trying to roll out NA, CA, and there's 31 types of mutual aid groups. So there's a lot to get through, but the different types of support for people, as well as we started doing Recovery Month about 4 years ago. So having different events that staff and residents can join in just to talk about recovery in lots of different ways. So just trying to get the information out there. And we are also rolling out OHID, which is the Office of Health Inequalities and Disparity, their FAMAS sessions, which is another acronym, which stands for Facilitating Access to Mutual Aid. So there's 3 sessions. We're rolling that out in a number of APs. And again, that's just to try and have have recovery available so everyone can see that change is possible. And we really like everybody to be linked into, as many mutual aid groups, peer support groups, SMART, etc. as possible. I've written a toolkit, a guide for how we can roll out recovery-focused APs, but how we can introduce recovery in all the APs. Some of the innovations I've already talked about, that prison tracking, so that continuity of care is really important, the recovery coach training. And I'll just pause telling you about something we've recently done about SMART. So if you're not familiar with SMART, it's CBT-based, it's self-management and recovery training. We trained some prison staff, some AP, 2 lots of AP staff, and somebody who is in prison as a cohort all together into being SMART facilitators. That prisoner can now deliver SMART in the prison. And when he comes to the AP, because he's on the tracker, he'll be able to do that alongside AP staff and then leave the AP with a qualification. That's just one of the innovations that we've really tried to do. And similarly, we're trying to do training SMART in another AP with EPOPs that Tim referred to, and those are engaging people on probation, people maybe that they've never been high risk, they've never been to an AP, but we're training them alongside AP staff so they can come back into the AP and deliver SMART. So those are just some of the innovations that we've done. The lessons learned, it's really important, as I said, to deal with the transitions, both coming into the AP, but also moving out. We did some research and we have resident diversity meetings every month in every AP, and the research from that group is saying, you know what, where you're not really putting too much emphasis on day 1 or week 1 when we first are released from prison, we actually want that. So we've now got a first week schedule, and similarly we've got a working title of Warrior Down, and that's for people leaving the AP to really help people deal with that transition leaving the AP, because in the AP, they're asked 27 times a day, how are you? Come do this, come do that, a lot of support. But maybe moving to an area they're not familiar with and not connected, which is why the C for Chime model is so important, to make sure that we've got a lot of connections. So we're dealing with that transition to the community as well. We've got research and evaluation underway, so how all this is working, and hopefully, in the next 6 months or so, we'll have some results from that, but that's underway. And just a call to action, if you've heard me race through that and you're thinking, well, what can you do? Well, if you're in prison and you're in a DRW, then, or an ISFL, tell people about what's going on, what we can offer in the approved premises. And similarly, if you're in the community and you've heard what I've said and you think, actually, I know a scheme, I know a project, I know something that could help people transition from the AP into the community, then please do get in touch. I think I've raced through that. Thank you, Mike.
Thank you, Jerry, for all of that. And thank you to all of those speakers, because as you can see from the examples and the insights that they've given us, it is possible to create a recovery orientation. It takes time. This is not something that's an overnight quick fix. This is something that takes time to build and it takes time to create. But we've started that process, and we think that that pathway, that journey that we're going on, will lead us to some more positive benefits and practice outcomes.